Good evening, Sushmita ma'am. Actually, I have met you many times in the LVP.
We are live, please.
All right. Okay. Can I? Mr. Sunil, we are live, so I can
Yes, ma'am.
go ahead? Yeah, we can start. So, good evening, everyone, and welcome to this webinar, which is a little different from what we usually do. And it's DNA meets the disc. So, for the longest time, glaucoma and genetics were, yeah, there is something in the genetics, but not really clinically useful. It was relegated to the lab, or at the most, relegated to congenital glaucomas. But that's not really true anymore, and it's come knocking at your doorstep. So we need to know genetics and how we can use it to have individualized glaucoma care. And for that, we have none other than Dr. Sushmita Kaushik, who is the professor at PGI Chandigarh. She needs no introduction in glaucoma circles. She has various awards to her name, and she's a wonderful orator, and she makes difficult things simple. Moreover, she has worked extensively in genetics by view of her doing a lot of work in developmental or childhood glaucomas, and they have several papers also to her name. So that's what we have. Thank you, Dr. Sushmita, for joining us here. Next, we have Dr. Chanda Hingorani. She's a glaucoma specialist from Mumbai, and she's going to present to us a case on juvenile open angle glaucoma and a family of JOAG. And next we have Dr. Sanket Deshmukh. He's the youngest of us lot. And he's a glaucoma person from Akola. And he's going to present about congenital glaucoma. And these cases will help us understand better how to use genetics in our day-to-day life. And we have somebody who's not an ophthalmologist, Dr. Shruti Bajaj, but is so crucial, her role would be so crucial for this webinar. She has done her MD in pediatrics and a fellowship in clinical genetics and master's in neurometabolism and cell biology from the University of Barcelona, Spain. So she is the director and consultant of clinical geneticists, the Purple Gene Clinic in Mumbai, and she will be able to give us further insights on how we should refer and when we should refer patients whom we think might require genetic counseling. So without any further ado, I request Dr. Sushmita to start her presentation on DNA meets the disc. So enjoy everybody this unique presentation by a wonderful orator.
Thank you so much, Preeti. It's my pleasure. And thank you for having me. So are my slides visible now? Are the slides visible?
Yes, they are.
Okay, yes. So thank you very much. And thank you, MOS, for the opportunity. It's always nice to share the little that you know. My first disclaimer is I am a complete clinician who's just trying to unravel a little bit of genetics for patients and for me to maybe bring it into the clinic a little more meaningfully. So I apologize if there are goof ups, and I would love to stand corrected and learn. So I always show photographs of children, but they're all with consent of their parents, because in context it helps us understand a little better. So the outline in the possibly next couple of minutes would be the basic terms used in genetics, because Preeti told me to start right at the beginning. And then the principal genes affected in glaucoma and genetic tests available, and some insights of how to choose what to do, and maybe one story of the clinic as to how it has helped us. So the first question, of course, would be when. So actually, there are quite lots of guidelines, and developmental glaucomas, early onset, and JOAG is one. The second useful scenario is when you have a positive family history. So many times you have somebody saying that my grandfather and his sister, we had glaucoma, and now how do we know whether and how often should we come for screening? So that is good if you have a proband, which means somebody who has a disease. So you can test that person and then just screen for the variant that that person has. And it gives you some indication as to how you would like to, or how frequently you would like to screen the unaffected member who is unaffected today, but might be affected in a couple of years now. So at least it's for risk stratification, we find it very useful. Then genetic counseling by predicting the risk of transfer. So you have a parent, you have a young couple of which one has glaucoma, and obviously they are concerned and say, what is the risk of my child having glaucoma? So in counseling, that helps. Then we've seen that in some variants, specifically CYP1B1, the variants can predict the prognosis. So if we do the genetic testing today, I can sort of prognosticate a little bit that this variant, in my experience in the last, say, 10 years or 15 years, has been particularly bad, or vice versa, this variant is very good. So even if your child has bad glaucoma today, don't give up on him. And remember, we work in a very, very, very resource crunch area, and our patients come literally off the street sometimes. So I'm a little dramatic. So I tell them, ek roti kam khana, but don't forget to put your drops and don't forget your follow-ups, and your child is likely to be reasonably all right. And then when the diagnosis is not certain, sometimes you have a plethora of things, you can't put them all together, and then genetics gives you an answer many times. So to start with, these are some common genetic terms which you would be hearing. So I've put this in this busy table, but if we dissect it one by one, the genome. So the genome is all the genes in a person's chromosome. So that's called a genome. So when you do whole genome testing, you test the entire genetic data in an individual. And then a gene. A gene is a small, a very tiny part of the DNA. It carries hereditary information about one particular thing. Color of the hair, sharpness of the nose, so whether you're a hairy skin or a non-hairy person, each one of them is coded by a protein, and that protein has a code which is in the gene. So that's a gene. So similarly, you have a gene for trabecular meshwork outflow, or a gene for corneal for corneal transparency, where if it's affected, you would have something called CHED. So then the next thing you would hear is a gene locus. Locus is from location. It's a region on the chromosome which carries that specific gene. So that's a locus. And alleles of a gene are present on the same gene locus on the chromosome. So this really is what we have. These are our chromosomes. These are all, I think, 7th class we've been hearing. So 22 pairs of autosomes and 1 pair of sex chromosomes. That's the one in red at the bottom. So this is what the chromosomal map looks like from largest to smallest. And these are what alleles are. So the alleles are present on the same gene locus. So obviously you get one from your mother and one from your father, but you have the same gene at the same location. And those complementary genes are called alleles because both would code for the same thing. So you'll have 2 alleles coding for hair color. You'll have 2 alleles coding for any part of your phenotype. And a genotype is the internal hereditary information, which is your genotype. What are you inside? And a phenotype is what is expressed outwardly. And that's important to understand, that you might have a genotype, but a phenotype is not expressed. It might be hidden, it might be recessive, it might be many things, but it's just not expressed. So whether or not that thing comes out in the phenotype is another question. Then you have dominant, which means one parent can pass on the trait to the child because that one gene is enough to cause a disease or a trait or a phenotype or whatever. And a recessive, of course, it's not enough for one. You need both alleles to be not functioning for the protein not to be found. So therefore, you need both parents who are carrying that one allele to pass on the disease to the child. So then following that is, of course, homozygous and heterozygous. I think we'll come across these terms as we go along, but I thought we'll just sort of set the playing field. So homozygous if 2 alleles are of the same type, and heterozygous if 2 alleles are different. So this is a heterozygous allele. I've just colored them different. And these are homozygous alleles, which means the alleles are the same. And here the alleles, the variants are different. A polymorphism, now these are terms which used to be used, it used to be called a SNP, a single nucleotide polymorphism. It's now called a benign variant. That's the classification accepted. That means when a variation in the gene is seen in at least 1% of the normal population, and usually it does not cause disease. So that's why it's a variant, but it's benign because it's not causing any deleterious effects. So we have variations in height, variations in hair color, variations in so many shape of the nose, but we're not abnormal. We are just variations of the normal, and that's what this also means, a polymorphism. Whereas a mutation, and we don't call it a mutation anymore, it used to be called a mutation, now it's called a pathogenic variant, which by definition means a variant which is pathological and it is disease causing. It does not let the individual be so-called normal. So the next important thing to understand is zygosity. So we've talked about that. A heterozygous means two alleles are different. Homozygous means both alleles have the same characteristic of both. And you could have something called a compound heterozygous, which means on the same gene, but you have two variants. If you have one from one and one from the other, this is called being in trans. So this can cause disease even if it is in a recessive state. This is compound heterozygous, but you can't just make out with the genetic report if there are two variants, whether or not it's compound or not. So you need to test the parents as well. But compound heterozygous is generally, in my experience, what we've seen is a little lesser severe than a homozygous in recessive disease. And of course, heterozygous, you need the disease to be dominant for the disease to be manifested. Because if it's not dominant, then heterozygous variants in recessive disease don't cause disease. So because the other allele and the protein is working fine. Right. So then, of course, we've come back to the gene. So this is what the funda is about. The segment of DNA located at a locus or a particular position on a chromosome, that's called a gene. It codes for a specific trait or contributes to a particular function. And it's a DNA sequence that is transcribed into RNA. So remember the DNA, but when it's transcribed or when it goes into the RNA, this is either be translated into a protein or function directly as RNA itself. So it's not actually the DNA which we are testing. It is actually RNA, but it is because it has been transcribed from the DNA, and that is what is tested. So of course we've understood what the allele is, versions of a gene. I like calling it a version of a gene at the same specific location in a chromosome. Right. So the other thing to understand is exons and introns, because we'll be talking of whole exome sequencing and genomic sequencing. So exon is a coding region of the gene that translates into protein. So you can see if this is a gene, there might be a little bit of promoter at the beginning, but these blue things are the exons, which are the protein coding parts of the DNA of the gene. Then this is transcribed into RNA, and when it's transcribed into RNA, both introns and exons are into it. And then when it becomes mRNA to form the protein, it is spliced. So when you have variants, you will see at splice site, which means the sites at which the introns are snipped off the exons, those might be deleterious as well. So it's important to have splice site variations also. And sometimes that's precisely what it means, that the site of the splicing, if there's a variant, then it could cause a deleterious effect on the protein. So of course, just a small recap, this is DNA in the nucleus. And then RNA comes, it's transcribed on it. That's what happens. And then it goes out. And then the tRNA is already attached to a protein, an amino acid, and they line up with these triplet codons, and then it's folded and it forms a protein. So this is called protein folding. So this is the bare minimum, the funda of genetic transcription and translation, and which is why it is important to understand that when you're doing an exome sequence, you're only doing exons and you're not doing introns. So you might have a regulator or a regulatory function in the intron for which the DNA, the exon might be structurally normal. So your report will be negative, but because you haven't tested for the entire introns as well, you might not be seeing the cause of why that person has a disease. So that's what will come with a whole genome sequence. If you want to test both exons and introns, you will have a whole genome sequence. Okay, So another bare minimum thing to understand is codon. So codon are 3 bases which code for an amino acid. There are always 3 bases, but remember there are 20 amino acids and only 4 bases. So many amino acids have more than one codon. And if you see this, now this is serine, suppose that's a protein. UCU is also serine. UCC is also serine. UCA is also serine. So you have 3 codons coding for the same protein, right? So that's one important concept to understand. And this is when at the time of forming the protein, you have these tRNAs which have these amino acids, and they have the triplets and they go and align themselves along the RNA which has come out. And that's how you get the protein. So what is a variant? A variation in the proband of the genetic makeup compared to a reference genome. So I'll just put in a typical report, and because I do so much of childhood glaucoma, CYP1B1 is the most common that we get. So this is your reference. It's important. It's like an edition of a book. So if you want to give a reference to a book, you will also have to give the edition, isn't it? So when you write page 63 to 70, you'll have to write which edition of Duke Elders it is, because Duke Elders 10th edition will not be the same in the page number of Duke Elders 5th edition. So this is like the edition of the reference chromosome against which this is being compared. So this is the NM number. This tells you it's in this exon, and this is the variant. Now, this is something it's very interesting to understand. So we just talked of codons. So what this means is this is C is for codon, P is for protein. So in this variant of the CYP1B1, the codon at position 1169, the G is substituted by A. So G is substituted by A, and it results in arginine becoming histidine instead of arginine. So obviously that protein is not being formed because this amino acid has been changed. So if you just see it here, I should have actually marked it out. So let's look at arginine, if we can find arginine somewhere. Okay, here.
Yeah.
So this is arginine, and if you see G is substituted by A. So if you have a G here and it is substituted by A, and this becomes CAU, so this CAU becomes histidine. So is that clear? So that's what the report tells you, that at this position, because the G, just a CGU became CAU, the arginine has become histidine, right? So that's precisely what this variant means. So the variant is that this codon has substituted and it has resulted in this protein being substituted. And always remember, since 3 codons make a protein, usually these numbers are, you can divide it by 3. So 1169 divided by 3 would be approximately 390. So the position of the protein is 1/3 of the position of the codons, simply because there are 3 codons to 1 protein. That's simple maths. So this is homozygous. This causes 3A, juvenile open-angle congenital glaucoma, and this is autosomal recessive. So if it's autosomal recessive, the zygosity is homozygous. This is also classified as pathogenic. We'll come to that later. And the coverage depth is reasonable, which means 61 times they have gone through this next-gen sequencing, that's called, and they found this variant every time. So this is reasonably causative of the disease. So that's what a variant means. So let's look at broad testing strategies. Now, if you just want to look at karyotype, a karyotype means just an overview of maybe a bird's eye view of what the chromosome is like. You can do a karyotyping, which is by light microscopy, or you can do CMA, chromosomal microarray, where you can see a microarray. The resolution is much more, so you can look at smaller deletions than a karyotype. A karyotype, you can't look at deletions which are more than about 5 to 10 MB. So it has to be a really large deletion or additions or substitutions of the entire chromosome for you to see it. And an example is Klinefelter syndrome, where a karyotype is enough. You don't need to go in for a whole exome or anything. They're not going to pick this up. So you can see XXY, and just a karyotype will tell you that. So CMA is the same thing, looking at a chromosome, but at a smaller deletion, smaller variations for a chromosomal microarray. And these are just to look for changes and in number and structure of the chromosomes. That's the broad bird's eye thing. The next thing we do is sequence analysis. You can do either a whole genome, a whole exome, like we just talked about, sequence the whole exome, or sequence the entire genome, which means exons plus introns. So exome is because we are only sequencing the exon part of it, which is the protein coding part of the gene, and not the introns, because we are not looking at the spliced out introns. And you could do something called targeted testing, which is panels, which means, okay, I think 22 genes are the most likely to cause glaucoma. So let me test just these 22 genes and let me forget about the rest. So it could be a little cost effective, possibly, but especially in a situation like ours, where we are not very, very sure, and the phenotype may not always be exactly what it is, we would miss out genes which are not in that panel. And many times I've learned so much simply because I've been doing whole exome, and things which I never in my wildest dreams thought of, those syndromes have come in with glaucoma, and we've been so much wiser because of that. Okay, so these are the broad strategies that we have. So these are the tests. I like this. So these are the tests available: the whole genome, the whole exome, a gene panel, single gene sequencing, or a targeted single variant. So we'll just go through these again. So we've understood what the whole genome is. That's the entire genome, right? So it's a complete DNA sequence, all genetic genomic variations, discovery of functional coding and non-coding. And this has about 3.5 million variants which are tested. It's costly, over about 1 lakh now. So it's not really used most patients. A whole exome is simply one tiny slice of this whole genome. So this is all that the coding part of a genome is, right? So this is targeted sequencing of the protein, is just about 1% of the whole genome. And instead of the 3.5 million, we have just 20,000 odd variants, which are tested here. But a lot of information is where we get from the coding region, because that's a protein. So much is unknown as to why our organism has 99% of stuff there, of genetic material there, even though the actual coding region is just this much. Then, of course, from here, you can take off a small bite from this entire panel and say that, okay, I want to test for glaucoma, I want to test for cataract, I want to test for, say, neuromyelitis, I want to test for optic atrophy. So you have genes for all of inherited retinal dysgenesis. So IRD panel, cataract panel, glaucoma panel, all of that is available. In our country, generally, the platform is the whole exome. If you write a panel, they will analyze just those genes, but they'll be doing the whole exome anyway. So that's how it is, because apparently I've spoken to the labs and they say it's just not cost effective for us to make libraries and of just panels. It's just better to run the whole thing and analyze just the genes that are asked for. So it's often to pinpoint a diagnosis, and when a person has symptoms that fit a wide variety of conditions, and when the suspected condition can be caused by variation in many genes. So that's when a panel comes in. This is from Bascom Palmer, really. So this is how a genetic requisition form of a panel is. And it says congenital cataract panel, variant 2, early onset glaucoma, anterior segment dysgenesis, a comprehensive eye panel. So all exomes which have been implicated in eye disease, all of them would be done, but they would leave out all the rest. So you can see a comprehensive eye panel has 1,255 genes. Cataract has 57, early onset has 42, anterior segment dysgenesis much more, has about 256. But vis-a-vis a whole exome, you can take your pick as which one do you want. So single gene tests look for any genetic changes in one gene. So it's typically used to confirm or rule out a specific diagnosis. Like if you have congenital primary aphakia, I just want to know whether he's also harboring FOXC3 or not. So I can ask for just a FOXC3, or maybe it is aniridia, there is nystagmus, there's limbal stem cell deficiency. I just say, okay, let's screen for just PAX6. So those are when you would do single gene tests. Sometimes you could do a single gene test by Sanger sequencing, and where I use it is to screen parents when I find a variant in the proband or the child. I just do a Sanger sequencing to screen that particular variant in the parent and just give a yes and no as to whether it has really come from them. So that's how this comes. It's targeted single variant. A single variant test look for a specific variant in one gene. When we know that this variant is known to cause a disorder, and it's often used to test family members of someone who is known to have a particular variant to determine whether they have a familial condition. So parental screening, in fact, when we find it in a child. So we use this targeted single variant very often for family screening. So again, I think this has come again. So we've gone through this. Okay. Now, once we understand variants, you will see something like an ACMG classification, American College of Medical Genetics. They have sort of made a worldwide classification system to standardize things. So there are millions of genetic variants in each one of us. If we do a genetic testing, a whole genome in all of us, we will go mad. All variants don't cause disease, so there's no point knowing about them. I mean, it doesn't matter, even if we have them. But then how do we know that a particular variant is causing the condition? So what they've done is, these are internationally accepted guidelines for the interpretation, and they've come out with 28 criteria. Largely, they classified into pathogenic, likely benign, and these are the ones which there's no evidence for either being pathogenic or being benign. So this is how it is. So if it's a VUS, that's a big bear in the room. I don't know what to do about a VUS. So most people really scratch their heads now, what to do about this? Benign and likely benign are present in the normal population, and experimentally they've been proven to not affect that particular protein function. So that's why they've been classified benign. Pathogenic is usually not present in the normal population. Obviously, that's why it's pathogenic. It's present in other similarly affected individuals, and it might have been experimentally proven to affect protein function. So these are the criteria normally required for a variant to be classified as pathogenic or benign. So this is the classification. I'm not going into the details, but this is available on any website, anywhere you can get what pathogenic means, what very strong, and this thing means. But anyway, that's how it is. Coming to the next bit, when you have a positive report. So for instance, this is a pedigree, and you can see by the pedigree, when you have a disease across generations, it is likely to be autosomal dominant. You test the proband who has come to you for neurofibromatosis, has the NF1 gene in exon 32. It's heterozygous and autosomal dominant, so that's why it is inherited, NF1, and the classification is pathogenic. This is a typical so-called quote-unquote positive report. So these are clinically actionable, which means that you need to take notice of this variant, confirms the diagnosis, identifies the inheritance pattern, and identifies the underlying genetic variant, which directs systemic screening. So for instance, if we had this and we had this, we would screen for optic nerve glioma, cranial gliomas. And if we have PAX6 aniridia, we would screen for Wilms. We would screen for FOXC1, Axenfeld. We would screen for cardiac defects, because these are things which are known. And once you have a molecular diagnosis, it helps you go along and do the systemic evaluation. Then the other thing it does, it expands reproductive options. So what that means is you could have IVF with pre-implantation genetic testing, which means it's an IVF. So you brush the embryos and you screen for these genetic findings, and you only select the ones which are so-called normal. So that this, of course, opens a Pandora's box for ethical problems. Tomorrow it might go, I'm very scared, I want golden hair and blue eyes. And then would you be, picking and cherry picking embryos to be implanted in? But that's another story. And then you could use a donor gamete or embryo, again, by screening them and being sure they don't have the variant. Or you could just adopt, which I think is the easiest thing. But you could also do a prenatal diagnosis. This is after the lady is pregnant. You could do a prenatal diagnosis using amniocentesis or chorionic villus biopsy. So the other thing is, look at the report carefully. So everything positive is not positive. Now look at this. 25-year-old male, glaucoma, spherophakia, lens subluxation, high myope. You get an ASPH, which is a Trabowsi syndrome. It's autosomal recessive, but it is a compound het. and there are two variants. So of course you need to screen the parent, but you screen the parent and be sure that these two are on two separate alleles. Because if this was on the same allele, this cannot be ASPH, this can't be Trabulsi's, and you have to go back to your lab and tell them that listen, if it is in, and this is called being in cis, this is called being in trans. So if you have both on one, obviously one allele is perfectly normal. And if it is perfectly normal, then this cannot be causative of that. So you've picked up two variants, yes, but it does not automatically make it a disease-causing variant. So these are things which you have to take care of. And here it's compound. Now, there's no way that on a whole exome, you can say it's likely compound heterozygote. How do you know that? So without screening the parents and doing a Sanger's, you cannot be sure that these two variants are present on one of the child or on both, right? So then many times we have a negative report, which is like this, no pathogenic or likely pathogenic variant. So what it means, one is the gene is not discovered. It's there somewhere, but we don't know that this particular gene is also positive. So that's one. Wrong test selection. They have a large deletion or a large duplication, and you've done a whole exome. A whole exome is not going to pick up a large deletion, or that you need something like a chromosomal microarray to pick it up, because a whole exome is only looking for smaller point mutations. Then wrong indication for testing and the complete phenotype not given. So you've said congenital glaucoma, full stop, but you haven't also said that they also have aniridia and they also have foveal hypoplasia. So the complete phenotype is very, very important. So then they might just look for congenital glaucoma genes, which are normally CYP1B1, LTBP2, TEC, and they'll say negative. Because you haven't told them that he's also got aniridia and he's also got foveal hypoplasia and he's also got all that, only then they will look for and analyze other things. So the phenotype is king, as Dr. Arif Khan says. And then variant in a region which is not covered in a test. So it just might be that that region hasn't been covered and the variant is there, and therefore we haven't found it. So it's important to be in conversation with the lab. And if you're really, really sure, maybe you can ask for a reanalysis. You can ask for something called VCF files, and you can have them reanalyzed elsewhere. So it's not always that the one lab is going to be correct all the time. So this, as I said, is that big bear in the room. I don't know what to do with them. I have spoken to many geneticists. Janie Wigg's version is, if you have, so my question is always the same. If there is a VUS in a gene which matches the phenotype. So if you have a VUS in a CYP1B1 with severe congenital glaucoma, Dr. Janie Wiggs would say, no, I will not accept CYP1B1 as causative of newborn glaucoma if the variant that you find is classified as a VUS. Dr. Arif Khan says, no. If you find a gene which is known to cause a phenotype, a disease, even if it is a VUS, it is a VUS because there's not enough evidence. But I would not throw it out of the window and say this is not. I would wait, and maybe there'll be more evidence coming up. So it means is there's not enough scientific evidence present currently to prove pathogenicity. That's all it means. It's an ACMG classification depending on the evidence which is available today. It does not mean that it is not pathogenic, right? So it is not clinically actionable today in the present moment. What more can you do? Reanalyze again. Keep them in one folder, get back in a year or two, tell your lab, just run it again and see what. And there are lots and lots of websites where you can check it yourself. There's Franklin. There's so many. There's, I forget, there's one more, Varsom. So there's Varisom, there's Franklin. You can go check it and they will give you a pathogenicity accordingly. Then you can test other affected and unaffected family members. So if there's a sibling, again with bad congenital glaucoma, also with CYP1B1, then you're a little more inclined towards. Now, if you have a sibling who is completely normal and have the same CYP1B1 variant, then you could tell yourself, listen, the same variant is in a completely normal baby. So maybe this VUS is not really causative of disease in this child as well. And of course, you can nominate your VUS or functional analysis, so that you need to have a really, really good basic lab and basic friends to do a functional analysis of this, maybe a zebrafish model or whatever. But you need lab support. I'm just going through this. I'm not going to read them. It's just to complete it. So you know that how do you know that it is less than 1%, right, in the population? How do you know it's a pathogenic variant? So these are and at the end of your report, you'll read all this. So the population databases which are used are Exome Aggregation Consortium, Exome Variant Server, DB-SNP, DB-VAR. So these are population databases, normal population databases, much as we do normative database on our visual fields. So these are population references against which your variant is classified as whether it's present or not. So you would have a report saying this was not found to be present in a population database of Exome Aggregate Consortium or something like that. So that's what it will be. So that's what it means. Then the other thing would be disease databases. So then whether or not it is found to be deleterious on ClinVar or OMIM or human gene mutation database or human genome variations. So all these are databases which have collated variants, what are reported for this disease, and your lab will tell you it is pathogenic because this was coined pathogenic in ClinVar, or this has been already coined pathogenic in OMIM. So these are the disease databases which they also look at. And then the third thing is something interesting. It's called an in silico prediction. Now, these are bioinformatics. Not that I understand any of them, but I know what they are. So these are bioinformatic tools. Again, they put the variant into these tools and then they predict deleterious, or they predict that it's not deleterious, or they predict that it's benign. But these are the others. So when you see that, and these are only for missense mutation. Missense mutation mean one codon, one base is substituted by another, which results in one amino acid being substituted by another, or one protein being substituted by another. So these are for missense mutation predictions. You have these in silico also. So you'll have a line in your, so whenever you go back and read your report, you will see population database, then you'll see ClinVar, and then you'll see these in silico prediction by this tool also showed it is benign, or it is deleterious, or it is whatever. So these are the three things against which the variant that your patient has is going to be assessed, right? Then the other thing is, remember I told you splice site. So if you have normally splice site variants are considered pathogenic by most people, but you also have splice site prediction tools where you can put them in and see. But most reports will not have it. They will say that it has a splice site and it is, well, I'm going into it'll be +2 or +1 or +3, which means how much into the exon in that intron the variant is. But anyway, so splice sites normally are taken as deleterious. So coming to glaucoma, because the DNA is done, I'll just touch upon the glaucoma bit. This is the crux of the thing. PCG, like I said, CYP1B1, LTBP2, TET, ANGPT and THBS, I haven't found any so far, but it's part of the database of congenital glaucoma, so I'm putting that in. But CYP1B1, LTBP2 and TET. LTBP2, remember, is now thought to be a fibrillin precursor, so it causes microspherophakia and secondary glaucoma. RF Khan doesn't believe that LTBP2 would cause a trabecular dysgenesis. He believes it's secondary glaucoma, but LTBP2 has been portrayed as being a PCG gene by other papers, but the jury is out there. But most people who are doing childhood glaucoma believe that LTBP2 mutations lead to microspherophakia and subluxations, which lead to intermittent angle closures, and removal of the lens is what you should do rather than angle surgery or CTT or something. That's one. Axenfeld, of course, we know, PTEX2, FOXY1, CPAMD18 is now coming in since we are doing whole exome sequencing. That's the beauty of it. If we were doing only single panel or genes, CPAMD8 was not part of it. Whole exome sequencing has shown, and we have a couple of CPAMD8 as well. NIRADIA, of course, PAC6 and ITPR1. ITPR1 is Gillespie, so it's syndromic. It also has cerebellar ataxia and all that, but there is also NIRADIA. But remember, there is a host of other conditions which have aniridia, which are not necessarily PAC6. So aniridia is not a disease. Aniridia is simply absence of iris. You could have CYP1B1, you could have FOXY1 deletions, you could have a host of other genes which are causing loss of iris, but not causing the other PAC6 related aniridia phenotype. And GOAG, of course, myocilin and EFE-MP1. I haven't found EFE-MP1, but myocilin also is very, very low on our in our genetic database. And we don't routinely do it, but since it has been reported in 2 case reports so far, I put in the pigmentary glaucoma as well. And that, interestingly, is autosomal dominant. So now I'm going to start asking my pigmentary glaucoma guys to possibly get their children into, for me to see if they have PDS as well. So as you can see, there is an overlap. So it's not that one thing fits all. So these phenotypes are something which are given almost a century ago. So remember, at that time, there was no genetics. So Axenfeld and Peters, PCG, and Iridia. So you see this genetic heterogeneity amongst all of them, which actually says that it's not true that one gene is responsible for one phenotype. We are possibly missing it. I think it's our problem. So that's it. And one story to just wrap it, don't miss the wood for the trees. And I love this. So this 4-month-old boy comes with corneal opacity in the left eye, referred to rule out glaucoma, no significant history. He also has telecanthus, epicanthus, long eyelashes, bilateral ophthalmos, more prominent in the right eye. You can see that it's a large eye, and this keloid-like opacity in the left. And this is the exam under anesthesia. You can see that the iris is stuck behind the cornea, and you also have a little bit of cataract with, of course, prominent iris processes as well in the other eye. So high iris insertion, prominent iris processes, and you have this vascularized, well-developed, elevated opacity. Our cornea colleagues called it a keloid. They couldn't understand or explain why there should be a keloid in this small baby. And then, of course, we did whole exam, and lo and behold, CRE-BPP, really? Rubinstein type B, likely pathogenic. And we looked at literature. There's no report of glaucoma and Rubinstein type B syndrome, but we looked at the other features of Rubinstein type B. And well, we didn't see all that, did we? Depressed nasal bridge, yes. Long philtrum, yes. Small upper lip, yes. The upper lip is, and the lower is coming out. High palate, bilateral cryptocortism, we didn't see that. We didn't look for it. And this characteristic flat spade-like digits in both the hands and the feet, and low set posterior rotated ears. And also some cafe au lait spots in the back. So we looked at all this after we got the genetic report and after we read about what Rubinstein type B syndrome is like. So we, of course, Sagarika published that a couple of months later, and the echocardiography and magnetic MRI was abnormal, but some Rubinstein type B do have this, but they don't have glaucoma as part of the phenotype. So we added glaucoma as well. And then after, so God wants to test whether we've learned. So parents notice excessive photophobia lacrimation, now looked at systemic features. So there you are, long philtrum, small lip, posterior low set ears, flat digits on both the hands and feet. And my senior resident comes and says, do you think this is Rubinstein type B? I don't know. Let's see. Just send these features and say, let's see what happens. And then presented with all that, no significant variant. So I said, no, there's no Rubinstein type B. You're looking at everywhere. He says, no, let's write and ask them. So you mail them back because you have said congenital glaucoma. You have not said all this, all the rest. So they're not looking for it. And then you write back and request to analyze the CRE-BPP better. And there you go. So you have a Rubinstein type B syndrome, CRE-BPP, and this is pathogenic as well. So you need to be in constant conversation with your lab. There are many reports which come back, which are so-called negative or normal, and then we badger them to look at it again. So, and then they come back and they would come back with a report which you think. So these are the insights. Rubinstein type B can present with varied ocular systemic findings. Glaucoma is an unusual possibility. Very few case reports, including one of ours, and genetic confirmation helps in better disease characterization, right? So this is just one example. I mean, I could go on for the whole day. Just one more point. We are trying a new strategy for optimal testing. So we've seen many babies with this phenotype, spindle-shaped cornea, ectropion UVA, severe iris hypoplasia. Sometimes it's aniridic also. Severe iris hypoplasia, and most are CYP1B1 R390H. Most. So we also published that CYP1B1 R390H is a genetic marker for neonatal onset congenital ectropion UVA. And when we did the Sangers of the proband, Sangers of parents, you don't need to do an NGS. It saves time and money. And the parents are carriers for the same variant and counseled for the next child, and they were very happy. So this is the same baby who is now about 4 or 5 years old. He's going to school. I've had to do an optical iridectomy. These spindle-shaped things never, ever clear. And they're quite happy to take care of this one kid. So now we do quick Sangers of the R390H because it's almost like a hotspot where we have. So we just do that. We don't even do the whole exome. And once we find an R390H, we just screen the parents with that. And the whole thing is done in about 4,000 or 5,000 rupees, the whole trios. So the Sangers is cheap. The Sangers, they take about 1,500 or 2,000 rupees. So if you have, and if you're doing it routinely, and if you're really, really sure of your phenotype, my residents now look at a phenotype and say R390H hai, and they get hell because what do you mean R390H hai? So they say no, and usually they're right because it does come out. So this testing strategy is a little interesting, but anyway, we've started doing that, and let's see. And when we don't find it, then of course the NGS is always there. So just screen with the Sanger. You don't find this particular one, just go ahead and do the NGS and see what you find. So the key takeaways is, at least for us, it has unraveled underlying genetic factors. It has facilitated early diagnosis. It's given us informed treatment choices and prognostication. And I'd like to acknowledge all my residents. I can't name all of them over the years who really take a lot of pain in helping us get through this. Thank you so much.
Thank you, Dr. Sushmita. That was a real in-depth lecture. Basics made so simple, but at the same time, we have so many questions for you. So that will take after we have the two case presentations.
Sure.
So Dr. Chanda, if you can start presenting, share your screen, please.
Yeah, I'll start. That was such a gripping talk, ma'am.
Really? Okay, thank you.
Oh yeah, it was amazing. Yeah.
I mean, genetics, such a boring subject can be made so interesting. So I'll quickly run through my case. I'll just... I'll skip the introduction slide. So I'm going to present a case report of a family where glaucoma spans generation. So this highlights significant genetic contribution in the pathogenesis of glaucoma. So the first patient of this family which I saw was a 36-year-old female patient who had come for right eye glaucoma surgery at a charitable eye hospital where I go. So she was diagnosed with glaucoma 7 years back, and left eye trabeculectomy surgery was done. When I saw, her vision in right eye was 6.9, left eye was 6.6. Intraocular pressure in right eye was 36 millimeter of mercury with maximum therapy, and in left eye it was 16 millimeter with 2 anti-glaucoma medications. CCT in right eye was 532 and left eye was 536. Anterior segment examination, right eye had little sluggish pupillary reaction. Rest of it was essentially normal. In left eye, there was a diffuse functional bleb and rest was again normal. Fundus examination in right eye showed a 0.9 cupping with bipolar notch. Left eye had 0.8 cupping with an inferior notch. Gonioscopy in right eye showed open angles. Left eye also was open angle with a partially patent ostium. So we did a right eye trap in 2023 and IOP was within normal range for about an year and then started spiking up again when she was started on anti-glaucoma medications. So currently she is on maximum therapy in both the eyes and maintaining a borderline IOP and stable fields. So this is the perimetry report of this patient. You can see advanced glaucoma in both the eyes. Left eye was operated first and the right eye we operated later on. So the second patient of the same family is a younger brother who also presented after a few months for again right eye glaucoma surgery. He was diagnosed glaucoma at the age of 25 years, and vision in both eyes was 6/6. And when he presented to us, his intraocular pressure in right eye was 38 millimeters and left eye was 16 millimeters with maximum therapy again. CCT was normal, gonioscopy showed open angles. So this is the perimetry report. Right eye showed advanced glaucoma. Left eye had mild or moderate glaucoma. So we did a right eye trabeculectomy surgery for him, and he's maintaining controlled intraocular pressure with 2 anti-glaucoma medications. Left eye is also stable with maximum therapy. Then the third patient who I just saw once, he is the youngest brother of the same family, and he was diagnosed with glaucoma at the age of 24 years. He's being treated at Ganpati Netralaya, and there his trab was done for the right eye. Again, left eye had controlled pressure with maximum therapy. These are his fields. This is the youngest brother. So advanced glaucoma in one eye and moderate in other eye. So it is a family of 6 siblings, 3 brothers and 3 sisters. 2 sisters and 2 brothers are affected with open angle glaucoma, and all of them were diagnosed before the age of 30 years. So both sisters had bilateral advanced glaucoma and had undergone trab in both the eyes, whereas both brothers had advanced glaucoma only in one eye and moderate in other eye and had undergone trab in one eye only. Other 2 siblings were unaffected. So this is the pedigree chart I made. So these are the patients that I had examined. Eldest daughter also had glaucoma. In fact, she had optic atrophy in one eye and an advanced glaucoma in the other eye, and she was operated for trab in both the eyes. So the mother of these 6 siblings also had glaucoma, and they were 3 daughters. So the eldest daughter had glaucoma, middle daughter had did not have glaucoma, and the youngest daughter had glaucoma. And their mother and father were normal, but their maternal grandmother, means their nanny, also was suffering from glaucoma. And one more significant history, actually I had remade the chart but not uploaded it. So this youngest daughter and the middle daughter had a consanguineous marriage with their first cousin, their bua's son. So both of them married their bua's son. And the eldest daughter, she had 4 offsprings.
Yes.
First 2 were not affected. Son and daughter were again affected by glaucoma. Middle daughter did not have glaucoma, and she again had 4 children, and none of them is suffering from glaucoma. And all these 6 siblings, they have. So I'll just go through it. So in this family, glaucoma appears in successive generations, affecting both genders with clear parent-to-child transmission, strongly suggesting autosomal dominant inheritance. I'll just skip this. So now we are worried what should be the management plan for the kids of the affected siblings. So all of them are married and they have kids between the ages of 5 to 15 years. Some of these kids I have examined few years back. That time they were not affected with glaucoma. But I want to know from Dr. Sushmita and Dr. Bajaj, what is the age at which first eye checkup should be done for them, and any genetic testing to be done for them. Also, what are the chances of unaffected siblings developing glaucoma later in life? I mean, do we keep on screening them every year? Out of those 6, 2 are unaffected. So I want to know the management plan for them, and also any need for evaluating the kids of unaffected siblings.
So I would take a
Can we,
proband.
Dr. Sushmita, can we take the second case and then have it, or
Okay.
should we have the discussion?
All right, as you.
Okay, we can have the discussion, right? Dr.
Okay.
Sushmita and Dr. Shruti, if you can. Yeah, you're there.
Yeah,
Yes. So now what do we do?
I would, as a clinician, maybe I would just do the, I mean, of course, myocillin would be the most this thing, but since we do whole exam anyway, so I would do one proband with absolute obvious disease and screen all the unaffected ones. And that would tell me the risk stratification, because if they harbor the same variant, depending on their age, JOAG might occur later. And if they harbor it, my screening strategy would be more aggressive. If they don't, I'd probably tell them, listen, most likely they're as good as 2% of the population, don't worry. And this middle daughter obviously is in the 25% who would be unaffected in all autosomal diseases. So I don't think her children would be so much, but definitely this family, I would do a Sanger's for all of them, for that variant.
Okay. Dr. Shruti,
Yeah.
how because
Yeah,
a
yeah.
lot
Am
may
I,
be affected.
am I audible, Dr.
Yes.
Preeti?
Yes.
Yeah, firstly, thank you for having me as a geneticist. I feel outnumbered. So if I'm going to say variant of uncertain significance, don't throw a tonometer at me, please. So yeah, point being, I think a lot of things were made easy by Dr. Sushmita. I want to differ a little over here. So there's this whole concept of incomplete penetrance. To put it in very simple words, I have inherited the gene, but the condition may not manifest in me at all. And then there's something called as clinical variability, which means I will inherited, I will manifest, but well, there will be a difference in the spectrum
Severity.
of the manifestation. I was very intrigued by the pedigree, and I was thinking of all sorts of, but let's make it simple. So when you're seeing a vertically affected pedigree chart, it's often autosomal dominant. When it's horizontally affected with more siblings, not parents, is usually autosomal recessive. Usually in the MyoC, I know, and I agree with you, Dr. Sushmita, we don't see a lot of it in India as against some other parts of the world. But we understand that especially the juvenile glaucoma can be not necessarily monogenic. It can also be polygenic. And Dr. Sushmita did touch upon it that there are some things, she put it wonderfully with simplistic examples like eye color, nose. These are things which, although they are inherited, they are there in our gene, we won't pick it with the current test. Imagine it as a one button, one light, and a multiple panel with dimmer of lights. If I switch off the one button, the one light will go off, that is monogenic. But if I have to turn off 10 dimmers to switch off the light, that's polygenic. So with autosomal dominant glaucoma, a lot of them can be polygenic, multifactorial in nature, where a negative exome, even a negative genome, does not rule out heritability. So in this case, we would err on the side, at least that's what I think, again, this is what we learn from each other. We always talk to each other, not just with the lab, but even with the referring doctors. I would suggest that, look here, you may not get any genetic answer at all, but doing an eye checkup is simple, inexpensive, non-invasive. Let's just do that for all the members, even if there is an apparent generation skipping, like say one sister is unaffected, it could be that it is incompletely penetrant in her, but her children may manifest the symptoms.
Sure.
And MYOC also has this genotype-phenotype correlation. You mentioned it for SIP1, but there's this Pro370 LU, which has more severe phenotype in MyoC. And if you find that, again, there could be some children who have very severe onset glaucoma, and then, vision would get deteriorated quickly. In the absence of a genetic report, err on the side of commission rather than omission. In the presence of a genetic report, if affordable, screen them, and only those who are positive go through this further thing. I mean, just a little bit of a difference in my opinion, but largely I agree with all of you all. Yeah.
So now this is a family.
Yeah.
Should we do all this ourselves because we don't have the knowledge, the wherewithal to identify which test to be done? Or should we be referring this family to a geneticist and then let the geneticist decide? Many times what happens, they say, kya chahiye? If I knew kya chahiye, I would not be referring because I myself don't know. I know that this family, there are a lot of people with glaucoma, but what do I do with it? So should I send the testing myself, or should I refer them to a geneticist and let the geneticist decide what needs to be done further?
Yeah.
Because
Yeah.
that is what I want to know, that clinically many of us are in the same boat as what I have said just now. So what
Correct,
should we
Dr.
do?
Preeti. So, of course, see, I think some of us really pick up the cross branches too well. So if you feel you're in the comfort zone with genetics, you could take it on, and then if you're stuck with some variant, you call on your friend, basically. But if not, if you think you're a starter in it, and I really think, as Dr. Sushmita was telling, that so many of our patients come from resource crunched areas, we don't have the luxury of ordering a test and then reordering it again because it was wrong, you know. So in such a case, it has to be kind of, I think if we're not confident, we just pick up a phone and we consult a geneticist and ask locally if you want. Some of us teleconsult our, so that's a part which I think depends on your personal comfort zone. But yes, I think before the choice of the test, detailing of the phenotype, checking for the systemic features. So I had a smile on my face when I heard about the Rubinstein type A. I was wanting to look for the talon cusps. So I think as a team, very often when we come together in a multi-D thing, the ophthalmologist will give a detailed ocular phenotype, which I won't be able to elicit. The geneticist, so together when the detailed phenotype goes, the patient stands at a best chance, Dr. Preeti, to have an answer after spending some hard-earned money. You know, and of course, not getting haunted by variants of uncertain significance. The sharper the phenotype, the better are the chances that you will be troubled by these, basically.
So what you're
I
saying
think,
is,
Preeti,
yeah,
your my take would be that no matter what, every patient should have a good pre-test.
I'm sorry. Yeah.
Okay. So everybody before undergoing genetic testing needs pre-test counseling. So if you're not confident in counseling them and telling them what we are expecting, why we are testing, and what would be the repercussions if we get a report or we don't get a report. So the pre-test counseling is the most important thing, rather than just shoot it off like a blood sugar or something. And if we understand what is it that we need to tell, it's okay for a clinician to do it. But if they're not comfortable with counseling, it has to go to a geneticist before getting a testing done. I think that information has to be very, very clear. That don't just shoot it off and call Medgenome or Redcliffe and say, do a test.
Yes. So counsel, refer till you're getting your bearings right. Go to a person who's actually qualified and trained to do it. And maybe what is the test you would do for these? Whole exome sequencing, what would you be doing? That's what you would be doing?
So I agree with so see, firstly, the cost difference between whole exome, clinical exome, and panels. Panels is equal to clinical exome. Difference between a whole exome and a clinical exome is barely 2,000 to 3,000. Even speaking in commercial labs, you know, I mean, in research labs, it would be even lesser. To top it, the coverage of clinical exome is reducing of late. A lot of labs are phasing out clinical exome. So I would go for a whole exome. In fact, I'd take a step further. Right since 2017, Dr. Srivastav et al. And a lot of data in place how trio whole exomes, that is child with parents, doubles the diagnostic yield. I mean, I know we are all debating about how can we save 2,000 for the patient, but you know, not all of them are such where they can't pay. There will be some who are affording, and there will be some crunch scenarios in terms of pregnancy, prenatal, where you cannot afford to spend 8-12 weeks on. Yes, in this case, I would go in for a whole exome. And yeah, and then yeah.
How much does it cost, whole exome sequencing?
Around, it depends on which lab do we, you know, align with. But again, ranges between, say, 14,000 to even 35,000, depending on which lab do we align with, basically.
Okay. All right.
We get it for 10.
Yeah,
10?
absolutely, absolutely.
Which
So
one?
I think there's a
From
PGI thing.
financial
I think it's a
interest?
PGI thing, but there's a lot of competition. And
Absolutely.
just to reiterate what clinical and whole exome means, clinical exome is the exons which have been known to cause disease in man, and whole exome is every single exon, regardless of whether it is known to cause disease. So that's one caveat here.
So I think this case, we know which way to go. Counsel, send to a geneticist, till you get your bearings right,
Yeah.
do the testing, let the interpretation be done, and continue to see the patient irrespective of, you know,
Whatever,
what the
yes.
gene, yes, shows. So
And one very, very important thing in our setting, Preeti, is to just send out that do not blame. You know, it's very, you have a
yes.
thing कि आपसे आया है. और
हाँ,
आप में नहीं है. So,
Okay.
that's also part of the counseling, and you have to be very, very sure that we don't say that. I mean,
Yeah.
especially in retinoblastoma, Dr. Usha
Yeah.
says families break up on this one.
Right.
Yeah.
Right. That's such an important point. Yeah, Dr. Shruti, you wanted to say?
I would want to add over here, even when it's coming from a parent, like
Yes.
X-linked, and especially in our country, we know the status
Privilege.
that a common woman would get. I've seen the other way around too. Like even if it's a man, we often think like, okay, he will take it easy. They already are reeling under blame and guilt.
Yeah.
So I have some takeaways and just sharing practical things. Some lines like 95% of human race is a carrier for at least 4 to 5 conditions,
Yeah.
and it just depends on what manifests, what does not. Suddenly reduces the
Guilt.
choke, even when it's recessive parents, and every doctor is asked तुमच्या नात्यात लग्न झालंय, नाता शादी किया है. So suddenly there's a guilt about marrying the person whom you're living for 25 years. So to tell that, see, we are not here to judge traditions, to change practices. It's just that people who are marrying within communities and within cousins are at a little more risk of these disorders. We see this in intercontinental marriages too. Suddenly eases the air in the room. I mean, we don't want a child to be blind and to lose his parents, right? I mean, to have a divorce. So these are just some things that I think, as very rightly said by Dr. Sushmita, that in the whole science part, we should not forget the social fabric.
Super. Very, very true. Very true. Point well taken. And Dr. Sanket, if you can now share your slides. His case is about congenital glaucoma. Again, very pertinent. Yeah. No, you're muted. You're muted. Dr. Sanket. Yes.
Thank you very much for giving me this opportunity. I will be presenting a case of primary congenital glaucoma and followed by a discussion how to go ahead when the family wants to plan for their second child. As we all know, childhood glaucoma has a very wide spectrum ranging from aniridia, Peters-Anamodi, Sturge-Weber syndrome, Axenfeld-Rieger syndrome. But primary congenital glaucoma is most common in all of these childhood glaucomas. And 1 in 3,300 live births in Western countries is affected by primary congenital glaucoma, but the rate is much higher in our country because of the high rate of consanguineous marriage. And childhood glaucoma is genetically complex, but in real world India, diagnosis is often delayed, and there is a limited use of genetic testing. So coming to the case, he was a 2-year-old male patient and complained of large side of the right eye and watering from the other eye. There was no significant birth history and no family history of similar complaints, as well as there was no history of any consanguineous marriage. And on examination, the right eye had a corneal haze, while the left eye showed presence of Roplus, which was positive. The scan showed that the right eye retina was attached and there was no leakage in the vitreous cavity. It was done to rule out any space occupying lesion or any tumor in the posterior cavity. The diagnosis was made that right eye had primary congenital glaucoma and the left eye had congenital nasolacrimal duct obstruction. On the EUA, the corneal clouding and HAPS stria were present. There was corneal haze, and the horizontal corneal diameter was almost 14.5 millimeters, and that in the left eye it was 11 millimeters. AC was deep, but the intraocular pressure was 28 in the affected eye and normal in the other eye. Fundus, even though it was seen hazily, there was a significant cupping as well as pallor was present in that eye. Gonioscopy showed open angles in both the eyes. This is a representative photograph of the HAPS stria, and the axial length in this patient was also increased in the right eye. And the CCT was higher, that's 568 millimeters, microns, and left eye 501 microns. Sorry for the typo. And the plan was to go ahead with the right eye trab and trap after 2 weeks of doing probing and syringing in the other eye. Probing and syringing was done and the trab and trap was followed. The surgery was uneventful and the cornea cleared up. In the subsequent follow-up visits, the patient was doing well with the amblyopia therapy. And in the patient's last visit was just 1 week back. He is now 4.5 years old, and IOP is also under control. This is his fundus photographs. In the right eye, the disc shows cupping and some amount of pallor. You can see, appreciate the ophthalmos in the right eye, but the cornea is clear, and hapstra is in the periphery, not occluding the visual axis. With glasses, the patient is recovering well. So now knowing this, that the glaucoma was unilateral, was not very significant. The phenotype was mild because the patient presented late with a mild corneal clouding, and there was no history of consanguinity. Keeping this in perspective, all these things in perspective, I would like to find out when the patient's parents are trying to go ahead with the second child, how should be the counseling, and how should we go ahead with this case?
Yeah, nice case. Very practical and something which is we face almost whenever we see congenital glaucoma. This is what we face. So, Dr. Sushmita, what would you do now? This child has been taken care of. Now, what would you counsel the patients? What test would you do? And how would you proceed, please?
So interestingly, unilateral glaucomas never give a genetic test report. Never. I mean, I'm really struggling with that. I spoke to Professor Deepak Edward, and he says that is your Nobel Prize winning question. You crack that and you win the prize. Nobody knows what happens. Why should just one eye develop glaucoma and the other eye be absolutely normal? And so I'm letting a cat out, and Sanket, someday you must follow this up because I haven't been able to. That he thinks it might be a post-implantation problem, which means it is after implantation. So it's only the cells of the part which is going to become the future eye. There's a variant, a mutation or a pathogenic variant there, but it has not affected the rest of the cells of the embryo. And because of that, you don't find it in blood or anywhere, but then it should express in TM. And I have tried. So the problem is that when you have the unilateral glaucoma, usually the cornea is not so bad. They're infantile onset. And GAT has come into my armamentarium. So by the time I've understood all this, I rarely do a combined trap and trap in these because they require a GAT. But whenever I do a combined trap with trap, I've been sending the TM sample. Unfortunately, they haven't been able to extract DNA from it. I have no idea why. But maybe because the sample is so small, or it's 1 by 2 millimeters, I don't know. But the answer is that how to counsel is going to be difficult in the sense that even if you do genetic testing, it is very rare for unilateral glaucomas to generate a genetic test report from the blood. It's like Sturge-Weber, where you'll never get anything from blood, but you'll get GNAQ if you take a skin biopsy. So that's an example of a somatic mutation, where only the melanocytes and the skin have the variant, and then the blood vessels there overgrow and form the port-wine birthmark. But yeah, so it's okay to, I guess, tell the parents, listen, we don't know. You don't have to know all the answers. So I tell them that with whatever I have seen, I really don't know. Because if it is a somatic mutation, it is possibly not going to be heritable.
Okay.
But the answer is I don't know. So I tell them that honestly, I really don't know. And in these people, you can't even have pre-implantation or amniocentesis or anything because you'll never yield anything, which is what I've seen. So they'll just have to take a chance. I think that's my take. Shruti, I'd love your comments on this.
So,
No, am I allowed? Do we
of
have
course.
time?
Yeah.
Yeah.
Yes, please.
So I agree, ma'am. I mean, post-zygotic somatic mosaicism is one of the possibilities why such a unilateral expression could occur. And very often in these somatic mosaicism, you said you sent across the tissue. You're right, the DNA extraction can be quite a tall task. So probably because of that, one may not be finding the result,
Yes.
I will take this opportunity to debust 3 myths. One, endogamy, that is marrying in the same community, is far more dangerous or equally dangerous as consanguinity. Okay, which for millions of years we Indians have got an expert at. We'll cling on to our community boundaries and make sure that. So because of that, it's behaving like a recessive gene pool. There's lack of exchange of genetic material outside the given community. So recessive genes tend to increase. There was a wonderful paper by Nakasuka et al. Called as a promise of gene discovery in South Asia in 2017, which pegs India to be the undeclared capital, sort of, in genetic disorders because of the huge practice of endogamy along with consanguinity. So, absence of consanguinity should not be a reason to exclude genetic disorders. That's myth one. Absence of family history should not be. 70 to 80% of genetic disorders occur without a family history. Point three, what Madam has already said, we cannot do, even if I have a spot on textbook diagnosis of Marfan syndrome in front of me, if I have not got his mutation, I cannot offer prenatal and pre-genetic for practical purposes. So if you are catering to such families and you know that they may be planning a baby, start the referral to the geneticist earlier on. There are something called as PLWUD, people living with undiagnosed disorders. It's a undiagnosed disorders is a huge chunk in genetics now, where we try to do transcriptomics, metabolomics, proteomics, unconventional methods of trying to arrive at a diagnosis, so that all this exercise can begin before she's pregnant and comes to us with just 10 weeks in hands. I know this, I'm digressing, but I just couldn't stop myself from bringing out these practical nuances. So, a long answer to a short question. I'm so sorry.
No. It was an
Yeah.
eye-opener. Now,
Yeah.
suppose this was a bilateral congenital glaucoma, and it's happened that the lady has already gotten pregnant, and now she's second time, and now she comes and tells me, how can I diagnose it early?
Yeah.
What can we do?
Yeah, these people will come to us on Saturday evening at 6 o'clock, and they'll come to us at 18 weeks pregnant. So the point is that here, definitely, Dr. Preeti, very often they'll come to you in pregnancy, telling that the previous child has it. Now help me prevent it. At this time, understand that as care providers, 4 weeks is the turnaround time for one round of test. So at such a time, it depends. If she's come to me at 6 weeks of time, I'll try to save her money, do a solo exome. If I get the variant, confirm it by testing the parents. I'll spend 4 plus 4 weeks, child and parents. Still by around 14 weeks, I will have some window left for amniocentesis, which would be at 16 to 17 weeks. So CVS, the option to do CVS is between 11 to 13. Amniocentesis is 16 to 17 weeks. But if she comes any later, we would have to do a trio exome sequencing. That is the mother, father, and the child together, hoping that you have to time your test in such a way that you get your answers inside 18 to 19 weeks. There is also something called as rapid trios, where you get the answer in 14 days, obviously at more cost. All of this exercise has some utility if I get the Taleka Chabi, if I get the mutation, if I get the fingerprint. Once I have got that, it's like getting the OTP of your bank account. I can then go down, do a prenatal, and find out and give her the answer what's the chance of recurrence. As we know, these anomalies would not get, these birth defects would not get detected by sonography, NIPT, dual marker, which is again a myth. डॉक्टर मैंने NIPT कराया था, मैंने dual marker कराया. How can my child still get primary angle closure glaucoma? So if such a lady comes, I would order a trio whole exome sequencing, of course, after detailed phenotyping, but offer the invasive fetal test only if I have got the targeted error and the mutation.
Otherwise, then it's just
They
give birth.
have to take the risk. We have to document. We always see a patient legally first, medico-legally second, and then medically. So we have to understand that we cannot afford to be in any type of trouble. At such a time, please document. Here, I would say, please get a geneticist in the loop, because you never know what else is happening. Is the phenotype inadequate? If you provide that, you'll get the answer before ordering a test, which is 40,000 plus. So in a prenatal scenario, please don't take it on yourself. Whoever is your geneticist of choice, please get in touch locally, teleconsult, but please get in touch with them.
So that's very well explained. Now it's already 9:20. I'll just in adult glaucoma, all this we have spoken about juvenile open angle glaucoma. Most of us are seeing adult glaucoma, primary open angle glaucoma, primary angle closure glaucoma. So where does genetic testing stand in these cases? I mean, what we have been doing is we tell them, okay, go, let's get your eye checked, let's get your pressure checked, do a baseline examination, and we see you every maybe 1 or 2 years, depending upon the age, or 2 to 3 years or longer. So is there any way genetic testing helps in adult glaucoma? So Dr. Sushmita, your take, and then Dr. Shruti.
Yeah.
I think what is coming in is a polygenic risk score, because adult glaucomas are all polygenic. There's no single gene with all of them. And there's also the fact of epigenetics. By the time you grow up, God knows what's happening in the environment to your genotype. So PRS is what Dr. Tedong is talking about a lot. So they not just look at your entire genotype or genome, but they also look at how different genes interact with each other, and is there a correlation of that interaction to your disease. So PRS is going to be the next. He says it's going to be like a sugar thing. You take a blood sample, put it to, say, press PRS and say yes or no. Well, God save us if that happens, but well, it's both for GWAS has taken out a couple of genes, but I don't think it is as significant now for us to test it in the clinic, especially since angle closure also has the angle closure component itself. You know, you do an LI fast, then you don't have the glaucoma. So then what do you do with the genetics and all that? That's my take, but it's very sketchy where adults are concerned. Shruti, what would you say?
Yeah, Dr. Shruti.
I agree, ma'am. Until and unless there is a very early onset with a strong family history, couples coming in for preconception counseling, where they feel it's affecting their again, that usually happens if it's very early onset, not the type of patients that you are describing.
Adult onset.
I don't think it often yields much. See, sometimes when the patient is still demanding, or they'll often do the test and walk into you, you can't do much, but the diagnostic yield would be very less. And I agree that PRS for conditions like autism, glaucoma, obesity, cardiovascular, these are the places where PRS may play a role, cancers to some extent. But I again, while I do deal in adult genetics, but I've not really catered to a lot of adult onset glaucoma patients coming to me, because the referral wouldn't come if there isn't something positive or it's not something worrying, basically. Yeah.
So, Dr. Sushmita, are you saying that polygenic risk score is something we should be doing, or it's just keep it in our mind that it's something like that may happen?
Polygenic risk score is again in comparison to population databases. And we don't have the population database in India as yet. So I don't think we can compare it to a Singapore ethnicity or something. So we don't have it yet.
So
These are the only thing which I keep hearing in various conferences. Somebody will have a talk on PR, and I listen very carefully. But the end of it all, it's what I started out with in the beginning. No, not yet. So that's okay.
So a takeaway would be that yes, every patient with congenital glaucoma or glaucoma of childhood needs to have a genetic testing done.
So.
Unilateral glaucoma is a little different. But adult glaucomas, okay, something may come up in the future, but we are not there yet in the Indian population.
Correct.
Is that what we can safely surmise?
Yeah.
Right. So I think we've got so much out of this wonderful webinar. I thank Dr. Sushmita, Dr. Shruti for her wonderful insights. Dr. Sanket, with your case, you brought out something so important.
Yeah.
Dr. Chanda, wonderful case. So thank you all, and I thank Entored for bringing about this webinar and putting things together. And I, Dr. Preeti Kamdar, Secretary of MOS, thank all of you for this wonderful time and sparing your valuable time. And good night to all of you.
Good night. Thank
And
you.
Thank you.
bye-bye.
Thank you. Thank you, Preeti. Yeah, bye. Bye.